Welcome, everybody.
Manly.
Just wanted to say welcome and thank you for everyone setting aside time to come together, and we'll get a lot out of this information from Theresa. And this is going to be one of many workshops and seminars that we're going to host for all our members and anyone that wants to get involved and learn more about their condition. As we're all sitting here, we all have MG, and we're all in different boats using different oars to get through and navigate our day. So I'm not going to say any more, and I'll pass it over to Theresa.
Hello, everyone. I hope you are well. Can everyone hear me all right?
Yes.
Awesome. Okay, so I'm just going to switch into my screen here. Everybody, we are going to do the Mental Health 101 today. So let me just... Alrighty, can everyone see that okay?
Yes.
Yep. Okay, awesome. So we'll start with who am I? My name is Theresa Maybury. I am a health educator, and I'm also a mental health and addiction counselor and clinician. So I do deliver talk therapy for the Canadian Mental Health Association for Haliburton, Kawartha Lakes, Peterborough, and Northumberland counties. So for today, the purpose of this presentation right now is just to learn the terminology surrounding mental health and wellness, learning specific illnesses, including common symptoms and presentation. I will call upon you guys, so you guys are welcome to jump in at any time. I'm gonna do my best to answer all of your questions surrounding mental health and illness, and I will want to make sure that it is clear we're not learning the skills necessary to provide that formal diagnosis. That's more in lines with a psychiatrist or psychologist, but I will, I always find it useful to learn more information. So if you guys can teach me something by the end of this too, that would be lovely. So we're gonna start with stigma, and I'm sure that all of us here has heard of it. It is a hot topic in the world today, as it should be, because vulnerable populations continue to be stigmatized against. So historical stigma it's actually a derivative of a Greek word, and that its origins referred to a type of marking or a tattoo that was cut or burned onto your skin of slaves or criminals or traitors in order to visibly identify them as a blemished or morally polluted person. And these individuals obviously were shunned in the society, especially pertaining to public spaces. So knowing the historical significance of that word, it really casts light on how debilitating stigma can be. So the stigma of mental illness, I'm gonna share some things. I would love feedback. So if we all know either how to raise our hand or just take ourselves off mute and jump in, I would widely encourage that. So people with mental illness are dangerous. What do you think?
No.
No. I think that you would have to be right. I think that are all people with mental health issues dangerous? Absolutely not. But we are people, some are. I also would like to share that oftentimes individuals with mental health issues are far likely to harm themselves rather than other people. I think oftentimes other people, because of their stigma, are oftentimes dangerous to the individual with mental illness, which we've run into all too common. Does mental illness only affect impoverished people?
No.
Definitely not.
Definitely not. Whether you come from a low line on the social status, low economic status, or high economic status, it can affect us all. As we've seen with celebrities talking about their mental health issues as well, right? People living with mental illness are responsible for it. How do we feel about that?
That's I find that's a big challenge for people, is taking accountability and ownership of their mental health, their physical health, their nutrition. I find it has to come from a base. And if you don't know where to start, then you don't know where you're going, and you don't know effectively how to communicate how your feelings can be portrayed to people that you're interacting with.
Absolutely. I think that there's some really great points in that. A lot of times people don't have the social supports, which oftentimes attributes to the exacerbation of that mental illness that they're experiencing. I think that learning the skills on how to cope, which is, you outlined beautifully with what you said, whether that be eating, whether that be seeking help, or gaining a stronger social support network like you have here. These are all steps that we can take to take accountability of some of the behaviors that come along with mental illness. But feeling our feelings in and of itself, we're not necessarily responsible for how we feel. It's how we navigate the world with those feelings, right? So I do want to get a point across. You are not defined by your mental illness, by your diagnosis whatsoever. I think that some points to bring up. The most recent consensus was 2019 survey that they did. So 75% of respondents said that they would be reluctant to or would refuse altogether to disclose a mental illness to employer or coworker because they were in fear of stigma. Respondents were 3 times less likely to want to disclose mental illness like depression rather than a physical one like cancer. And the top reluctance of that being the belief that there was a stigma around it and not wanting to be treated differently or judged. Who here has a family worker or a family member, somebody that they work with, somebody that they know who has mental illness?
I do.
I do.
Okay. And are they comfortable with sharing that to the world?
No.
Depends
No.
on the day.
My nephew has a drug problem plus mental illness. He's on some pretty serious drugs, and he hallucinates and he's talking to himself. So he's only 33 or 34 years old. It's really too bad.
Yeah, so I will say, being a therapist here, I deal with addiction management all the time, and it really is meeting people where they're at rather than where you want them to be. I think that is the biggest catalyst for change, and you can prescribe that to anything. You have to be realistic and time oriented and specific and measurable for all of these things, right? But I think shame is a common feeling, and we all know that all too well. We're worried about fitting in. And I think that when people don't meet us where we're at is the most common cause of suicidal ideation, depression, the lack or isolative measures that we take on ourselves. So it's really important to combat that stigma. How would you all think to combat stigma? What's the biggest catalyst for change in stigma?
I was going to offer, I like how you phrase go to where they're at.
Mm-hmm.
And that's not easy, because then you sometimes are putting yourself in your personal uncomfortable setting. You may see them at their worst, and that's when you need to see them. So then you can better understand where they're at versus, well, they'll get better, and then I'll go over and visit them. Then we're not going to get the true picture of where they're at, because we don't want to see them at their worst, because we're mentally not prepared to address that.
Yeah, and I think it's important with what, to go off what you said, to notice our own boundaries and limitations with that too, right? We all want to be supportive, but not always is the best way to support the individuals in our life, whether that be ourselves, with ourselves, right? So we might not be the best form of support for that person. So in that case, you can utilize your social network there in support services or counseling or psychiatry or hospitals. And it's good to note who is our safe people and who are unsafe people. So not all the time can we share our personal renditions of ourselves with unsafe people, because that's likely going to result in a negative experience, right? But I think tackling stigma overall is basically just teaching people, right? A lot of the reason why people have stigma in general is because they are ignorant to the overall factual information pertaining to whether that be mental health, whether that be a physical diagnosis or not. So I think that meeting people where they're at with the information that they have and expanding on that further with the information you have is a good way to combat stigma.
I've noticed there's a lot of change in the public world, celebrities and other people taking breaks from things, canceling music tours, doing different things because of their mental health issues. I used to work with students at the university, and 10 years ago, they would just say, I took a break from school. And even 5 years ago, they'd say, I had mental health issues. I took a break. I need to come back at part-time or whatever. So people were self-identifying as having mental health issues. There was a lot less stigma than there was even 10 or 15 years ago. So I start to see a more public face of folks with mental health challenges.
Absolutely, I'd have to agree that the stigma where we were and where we are has immensely improved. I think, has it improved to the point of there's no working on it anymore? Definitely not. But you are absolutely correct in the fact that people are being more open and honest with it. And I think that's only going to help individuals navigate their daily life, because it's important to list our limitations, right? It's important to recognize them, and it's also important to share them, because how are other people supposed to know our limitations if we don't tell them, right? Sorry, Tony, I saw your hand up.
Yep. There. I was just wondering, is there a difference between, say, drug addiction and mental illness, or is it a combination of both? Because my nephew he was pretty well a genius when he was going through school. And all of a sudden he got into the wrong people, the wrong hands, and he started taking drugs. And now his mind is I would say it's completely gone, which is unfortunately just waiting for him to take the wrong dose, and he's gone. And he doesn't want to help himself.
Yeah, good question. I think that oftentimes there's comorbidities with addiction and mental health. You don't usually have one without the other. Oftentimes addiction is their coping mechanism, right, for their mental health issues. Whether that be a mental illness, that might not be the case. So they might not be diagnosed with a mental illness, but they have extreme mental health issues that they self-soothe with addiction management, right? And really and truly, let's unpack some of the things that you said. He doesn't want to help himself.
Right.
If you meet him where he's at, he is helping himself with the addiction, right? So that is his self-soothe management. And I know that this gets very tricky when we entangle the personal relationships in it, because you hate to see it happen to him. And oftentimes addicts hate to do it to themselves as well. So really meeting him where he's at, trying to get to the bottom of why he's turned to a substance in general, because yes, it is biological in the sense that we are addicted to the substance, and there's chemicals interactions in our brain that's happening to make us want the next score or hit, what have you. But there's also a socio-emotional component to that he's trying to fill a need that has not been met otherwise. So there's a lot of
the question I would have, question I would have in his particular case, both his parents are at it's like Al-Anon or something, like the I can't even think of, they're going to a society where they're treating them, or they're telling them it's not your fault and there's nothing you can do for them. So, so my brother and his wife are in between a rock and a hard place. What do? Do they help him or don't they help him? And he's not allowed to come home anymore. So he's got to kind of fend for himself. So.
Yeah, and that goes back in line with the boundary setting that we discussed before, right? Whether that be a boundary that he's not able to come home. I think that oftentimes you'll see addictions resurface in people's lives when they want to make a change, but we can't force them to make a change because we want to, right? And that goes in line with autonomy. And if you're forcing somebody, whether they do it or not, if it's not for themselves, they're likely to go back to the substance. And that's the toughest part about all of addiction management, is dealing with the families that are affected by this. So what kind of language do you think that is helpful here? So mental illness obviously does have a stigma built into the language that we do use every day. So Joe is schizophrenic.
Yeah.
What is
Joe is an alcoholic.
Joe's an alcoholic, yeah. So what's a better frame of language that we can use to just combat that stigma in and of itself?
What I've done, I have a lady that's bipolar, and I think she told me to scare me. And my comment is, okay, you have a chemical imbalance. Doesn't mean you're any different than anybody else. It's just you have an imbalance somewhere.
Yeah, or living with, right? She's living with bipolar. She is not the actual diagnosis in and of herself, because let's say Susan is her name. Susan also is a mother, is a sister, is an athlete. There's so many multifaceted different directions that we could go with this, but you are not one formal diagnosis. And I think that's important to mention in the language, is you are not your diagnosis. You have the diagnosis, but you are not it. Okay, so let's go to facts. So quick facts. 1 in 5 people in Canada will experience mental illness in any given year. 75% of that mental illness appear before 24 years old. 1 in 10 Canadians will experience depression at some point in their life, and 50% of those will experience more than one episode. So today, approximately 5% of male youth and 12% of female youth aged 12 to 19 have experienced one episode. So going back to that, 50% of those youth will experience more than that one. At least 20% of people with mental illness can have a co-occurring substance use problem. So just going in line with what we were talking about, Tony, 20% of people with mental illness will have a substance use. So there is a comorbidity there, right? What do you think happens if the talk about mental health issues and mental illness gets silenced?
I think it'll just get worse.
Yeah, get worse. What is the worst that it could get?
Suicide. Yeah, we saw that
Or
with students. Yeah.
Suicide, or they'll be doing harm to themselves or others. But like what's happening here in Toronto on the subways in particular.
Yeah, absolutely. Yeah,
it's terrible what's going on. Sorry, go ahead.
No worries. So just to give you a little rendition here, about 4,000 Canadians die per year by suicide, and an average of almost 11 suicides a day. And that was in 2019, and I can only imagine that it has risen, and it affects people of all ages and all backgrounds. And on a per capita, there's 75% of suicides involve men, but women attempt suicide 3 to 4 times more often. Why do you think that there's such a high imbalance there of those who complete suicide being men?
I think men know how to do it, and women want to do it, but they don't really want to do it. They have their conflict with themselves.
Okay.
Guns, I think in the States especially, it's guns, death by guns. People may have more access to
Correct. Yeah.
I
meat
have
other than pills or
another
something.
I have another perspective on that. I feel that there are less social network opportunities for men than women, not because we choose, there are less men. I just think that we choose other forms of communicating with other men. And usually it's through a physical activity, whether it's a sport related or quasi sport related. And then usually in society, sports are connected to some type of, alcohol or some other addictive connection, where women, they talk a lot more, and they talk a lot more openly about their day-to-day challenges, where typically men choose not to.
Absolutely. You hit the nail on the head there. I think that there is a wide, vast undertaking of social support networks for women rather than men. Men, I think that going aligned with the stigma, are often deemed as soft when they do talk about their emotions.
Right.
And that is a negative stigma, and I think that we need to abolish that as well, right? I think that we all have feelings, we all have a right to share them with individuals, and I think that also Kathy hit it on the head too. Men are more likely to commit violent suicide attempts, and that violent would be jumping in front of a train or off a building, completing suicide by gun. So whereas women often takes pills, and then they are revived. So it's not that they wouldn't be completed, it's that they are in places where people have revived them. So, and a good quick fact for you is more than half of suicides involve people aged 45 and older. So these are just good facts, good knowledge to make sure that we dispel stigma as much as possible, right? So again, the language, mental health problem. Oh, sorry, go ahead.
What is your strategy or thought on visual cues? Like, I know I'm sitting in my office right now and I'm surrounded by positive visual cues that reflect my life, from all the activities, from my athletics, my scouting, people I've met in the world. I have photos literally around my room of all people, like astronauts, athletes, politicians, socialites. And if I'm not in a right mindset, I'll just literally turn around and I'll see Lou Ferrigno, or I'll see Chris Hadfield, or I'll see, Roberta Bondard over here. And then just look at them and I think, okay, I can do better. Rick Hansen, I can do better. I can look at Terry Fox's picture over on my left here. I can do better. So that's what gets me out of a quasi funk.
Yeah, and I think that can be very beneficial for certain individuals. I think you really have to cater and tailor it to you. In terms of narrative therapy, I love narrative therapy. I will always stand by it. I think that we need to challenge our internal narrative. All of us have this id and ego in our head going on that sometimes turn to negative thoughts, right? And I think that it is important to understand self-fulfilling prophecies in our life, and we do have to take accountability in our own suffering and how we can combat that, right? So whether that be visual cues put up on the board to maybe stop those negative thoughts or those ruminating thoughts that continuously happen. And you look to it for motivation. But oftentimes I think it's beneficial to stop the thought and say, is this inspiring? Is this true? Is this honest? Is it helpful? Is it kind? And can we kind of combat that thought? So let's say, let's use a trivial one. Let's say I'm horrible at presentations. I really don't like them. Well, is that helpful? Is it honest? Is it kind? Is it true? Have I ever delivered a presentation that's gone very well? Probably, right? If you're doing a task, or even if you haven't done a task, a lot of my depressed patients come into the office and say, I have no motivation to do anything. Well, let's combat that narrative, because you are here in front of me. So you got up today and you're trying. And it's little just micro changes like that can really affect your outlook on life. And I always use, I graduated neuroscience, so I'm not going to go too sciencey on you, but I would like to use the analogy of a jungle. When we're in a jungle and there's a paved path, it's so easy to go down that paved path, right? And oftentimes our negative thoughts, our negative line of thinking is that paved path, and that positive thinking, that one little micro alteration in life will be us physically cutting down that jungle and walking through it. So over time, it's going to get better and easier to reroute our neural circuitry, which is what I'm explaining, neuroplasticity, to reroute that, right? Oh, is that somebody talking, or?
No, the fire alarm gone off in our building, so.
Oh, okay.
Thanks, Tony.
I just wanted to make sure that I wasn't interrupting somebody.
I don't have to run away yet, so once it reaches the door, then I'll run.
Okay.
Okay, thanks.
But yeah, so I think that we can alter our thoughts, and sometimes we need a little bit of help with our social supports to do so, but that is possible. So just to get back to our presentation here, the language surrounding mental health problems and mental illness, I think there is important to make a distinction there, because mental health problems are common struggles and difficulties that affect us from time to time. And we all have that fluid range of thoughts, right? We are human. We are able to feel all of the feelings, and it is okay if we are sad sometimes and we experience depressive symptoms. I think it is important to distinguish that you don't have depression if you experience depressive symptoms, right? And that's just an example. So mental illness is a diagnosable condition that usually it requires treatment, and it requires a diagnosis from the DSM-5 criteria, which would be a psychiatrist or a psychologist. So, and this is kind of just my overview of all of the things that we can experience, right? So our external factors are whether we've had trauma or experience, whether we have workplace stress, personal stress, genetics. These can all affect our internal stressors, which lead to mania, psychosis, depression, worry, or fear, schizophrenia, what have you, all accumulate into and amalgamate into what our life experience and how we navigate that, right? And oftentimes impair our function. So it's really finding means and methods that work for us to cope with these. So just to go with depressive disorders, I think that it is important to note that our feelings are on a continuum. So it won't be linear ever. And we all know this in life. You can't be happy all the time. You can't be sad all the time. But individuals experiencing and having depression, it is debilitating. And oftentimes their normal range, that you see the normal range there, it doesn't break that past baseline of happiness. It's just a normal range followed by extreme bouts of sadness. And it is important to note that sadness is an emotion that everyone will experience at one point in our lives, be it the loss of a job or the end of a relationship or the death of a loved one. But when it comes to depression, there's no such happiness trigger that we can kind of use to get over a person suffering from depression feels sad and hopeless and may have even every reason in the world to be happy, which is very triggering for our family members around us, but they lose the ability to experience joy or pleasure. So it is an important distinction to note there.
Theresa,
Sorry,
can
go
I
ahead.
ask you a question? And with all of us having MG, how would you categorize or quantify loss? And it reflects as an individual, because for me, I was an athlete. There are things that I just cannot do anymore, and I had to get my mind to the point of, okay, well, I may never skate again. I may never run and catch a ball again. I may never jump and swim as a triathlete ever again. And that I spent close to 30 years doing. So in my life, that chapter is gone. So how do you qualify that as loss? And do you have any advice?
Yeah, I think that grief and acceptance therapy would be the most beneficial here. I think that redefining our limitations and our boundaries are adequate, like we were talking about before, and accepting it for what it was. You said the chapter is done in your life, but that doesn't mean that it didn't happen, right? So I think that accepting it for what
it was a big part of my life.
Yeah, it's a huge part of your life, right? I think that accepting things for as they are and what can we do to change things to gain more purpose in life, redefining purpose is scary. And it's all too common that people come into therapy with an immense amount of fear and anger regarding the loss that you're describing, right? But it's really redefining what you can look forward to, redefining our purpose and redefining our individuality through rediscovery that I would look forward to in therapy. Grief and acceptance therapy is always tough because it's an unchanging variable, right? For your limitations that you're describing, if you have limitations now that prevent you from doing those things, that is mourning. So you are mourning, and a part of mourning is accepting what it is and what we can do to change. So whether that be finding a new hobby, finding a new friend, sharing your experience, educating others, you can pour into a lot of different avenues in different ways, incorporating that old habit. So going to educational talks about MG for prior athletes as well. But re-engaging that old activity that you do love into a new one or a new form of the old activity would be one of my recommendations for that.
Yeah, speaking on that, I just discovered walking soccer. I'd never heard of it until 2 weeks ago. And apparently it's a big, big activity in Europe. So I immediately contacted Soccer Ontario and former associates, and I said, do you guys do walking soccer? Yeah. Where do you do it? Okay, there. So, okay. Because I used to coach at a high level. I used to play at a high level. I couldn't even imagine playing soccer, but I can walk and I can roll a ball, but my mind is all about strategy and techniques and all of that. So it makes me feel that I'm still part of the game.
Yeah.
When I heard about walking soccer, it's like, wow, I think I found my new sport.
And I think that having the motivation to look into those things is half the battle, right? To share a little bit, I was a national athlete for soccer as well. So just having a little bit of resources and motivation to looking into how can we incorporate a big part of my life that I did love into my new boundaries that are on me, whether that be limitations bodily or mentally, right? So I love that you found that, and that's such a great story to share. Thank you. So just a little bit more of an explanation of what qualifies the criteria for depression in the DSM-5 is that the mood persists for at least 2 weeks without lifting. So there's no lifting, there's no hopeful attitudes. The feelings do deepen over time and it starts to interfere with our daily living. So it actually can manifest with physical aches and pains as well. Because the way we perceive pain in the somatosensory cortex, it is in line with our mental health and physical health. So you can actually have bodily aches and pains, and oftentimes with individuals with MG or other neuromuscular deficits, is they experience an exacerbation of pain when they are coupled with depression and loss of functionality. So some symptoms: worthlessness, helplessness, hopelessness, sleeping more than usual or less than usual. Same with eating more or less. Difficulty cognitively functioning, making difficult decisions, loss of interest, the motivation, loss of energy, overwhelm. A sense of overwhelm and overstimulation is common in sadness and grief, and thoughts of death or suicide. So I will talk about a little bit of resources that we can have after available to all of you later on. So anxiety disorders. Anxiety disorders include disorders that share features of excessive fear and anxiety related to behavioral disturbances. So fear, the emotional response to real or perceived imminent threat, and anxiety is the anticipation of a future threat. So I did want to make that distinction before going forward. So a normal signaling response is that we have a danger. So I'm going to give my example in soccer. So I had a danger. I jumped up for a header ball. Somebody came under me, pushed up on my back and made me flip over. My kneecap hit the ground. My kneecap went up. All of my ligaments tore at the same time. So that's danger, right? My ears hear my body hit the floor. My nose smell the blood in my mouth. I taste the blood in my mouth too. I look down to touch my leg and my kneecap is divoted. So brain registers that danger. Do you think my heart rate was fine? You think I was normal? No, definitely spiked up, right? Heart rate, alert, tension perception, all elevated, that cortisol through the roof, right? And then it evokes a flight or fight response. So a fight response, this response could stem from the unconscious belief that maintaining power and control over others will lead to the acceptance of love or safety that we need. And a flight response, in short, is characterized by the desire to escape pain or distress. Does anybody know two other responses that are closely associated with a fight or flight now that they've come out with? Has anybody ever heard of it?
The fear. Oh, sorry. The freeze. Isn't freeze? Is that what you're
Freeze,
trying to
for
get to?
sure. Do you know, can you explain that to the group?
I guess if a bear is coming along, you want to play dead. That's kind of scenario where you don't move.
For sure. So the freeze response is a stalling tactic, basically. Your brain basically presses the pause button and remains hypervigilant and waiting when watching carefully. There's another one to go along with the freeze response, actually, flop. And that's basically all of your body just goes limp. Because it could benefit you in that moment, for the bear example specifically. And then there's a fawn response. Has anybody ever heard of that? No. Okay, so a fawn response is a response evoked to escape harm, and in short, by learning to please that person threatening you and keep them happy. So this is often actually seen in assault cases or domestic abuse. And it's just essentially ignoring your own needs to take care of the present, future moment. And that's the response. So all of these responses are evoked from a danger. What's different with anxiety is that all of these responses are still evoked, but with no danger. So fear characterized by behavioral disturbances, and it might not relate to any underlying condition, right? Maybe stress caused from work or from that person or from emotional trauma. But it is persistent, and excessive anxiety and worry about activities that are entirely routine can be evoked. So who here has had anxiety in an uncomfortable situation where they don't like the person?
Don't like the person?
Where they don't like the person that they're interacting with.
Oh, yeah. Many times. You can't
Yeah,
like the
right.
person who's in the meeting beside you, and you just have to find a coping strategy to get through the meeting without wanting to do something that is illegal.
Okay. Yeah, so these are all valid, right? And that would kind of tap into your fight response, so you go anyway, right? But some people would react differently, and it depends on what your natural response is going to evoke. But anxiety, I want to get across that there is no imminent danger, and we still experience an undue amount of stress.
I was gonna offer something that's relevant to all of us MG, and a little thing like going into a grocery store and you don't have a necessary mobility support with you, and you build up this mental level of anxiety of, okay, I can get there, I can drive there. Am I going to be able to walk in the store and get what I need and then get out? Because the other person I normally rely on isn't available, but I really need to get that item from the store. So I've experienced that where I've got in the store and I've pushed the buggy out, and then I got all my groceries in the car, and then my legs gave out. I literally could not walk the other 2 or 3 feet to the rack to put the cart away, and I hit the ground. And then I look up, and a stranger is helping me off the ground. It's like, oh, crap. So
the solution to that, Manly, is shop online.
Yeah, I thought you were going to say send your wife.
No, that's a perpetual cycle.
Those are real
Yeah.
living experiences for many of us. And it's a matter of just finding various ways of coping where, walker wheelchair that I had to buy, or a cane with a seat on it. And then choosing, do I take it with me? Am I capable of going into that short distance? And those are all games that you play with yourself to decide, how do I want to be successful?
Yeah. And I think that a safety plan is in order, right? And in some coping mechanisms.
Absolutely.
I do those often with my clients. Safety plans are important to distinguish our limitations or to help us live by them, right? So with that being said, though, in those environments or in those situations, do you find it's likely that to find people that are willing to help?
Always.
Always.
Yeah, always.
That's so good to hear.
Yeah, and I find sometimes where I don't need my cane, I will take it with me anyway, because it'll conjure up a conversation. So that gives me an opportunity to share my MG with someone who's kind of looking at me like, oh, that's a cool cane with a seat. Well, you got 30 seconds, I'll give you a story.
Mm-hmm.
So sometimes I take that device with me, hoping that I have an opportunity to have a conversation with someone.
Yeah, and
it's not just that I need it, but I need it in case, but I use it now as a vehicle of a conversation.
And I love that vehicle too, because that works to what we started talking about initially, and dispelling that stigma, right? It's just teaching individuals who would not have known otherwise how to interact with it.
And I'm not afraid to have that talk with a complete stranger.
And nor should you be. right? So
I
has
was
anybody
at a point. I was a couple years ago. I was afraid to even say that I have a disability or say that I have MG because I didn't have all the facts, and that's how I function. I don't have a conversation with someone if I don't have enough facts. I don't want to come off like I don't know what I'm talking about. So I would hold off having those kind of conversations until I'm comfortable enough sharing the facts.
Mhm. Linda, were you going to say something?
Nope.
I had some question as well. Like with my myasthenia, I get uncontrollable seizures when it's not
Okay.
controlled, and I'm on 4 or 5 different seizure medications, but they do not work when the myasthenia is not under control.
Okay.
And I find I get anxiety over that. Like recently, I had a real bad seizure in front of 4 or 5 friends, and then for a couple of days after that, I get a little embarrassed and depressed because they witnessed a seizure and whatnot. So that's one thing that does give me big anxiety, and a bit about what Manley was talking about as well. Like I had to give up blind hockey a couple of years ago because that was my favorite sport and everything. So eventually I moved on to blind curling. The doctor said, yeah, you can do curling, like this kind of thing. And so that helped. And I find for the anxiety as well, going on long walks, like going to the park kind of thing, that kind of helped a little bit as well. Socializing with friends, some of those things kind of help ease it a bit, but there are times where they jump for, it seems like for no reason at all. But I've heard that epilepsy and anxiety seem to go hand in hand, like in depression sometimes can seem to go hand in hand as well. But yeah.
Yeah, and Sean, about a part of your safety plan now, if you are hanging out with friends, do they know what to do? Did you develop a protocol? Let's say if it lasts longer than 2 to 5 minutes, are they to call the hospital? Like, you don't have to share this personal information, but using this as kind of a voice on what to do and how to handle these situations could teach other people, right? If you're comfortable at doing it with yourself and your friends, that's great. But if you're not, in general, educating people surrounding this, this is your life and we have to live it accordingly, right? So helping other individuals to understand and mitigate that stigma is an awesome kind of way to have a conversation, like Manley said.
My friend, I have it on the wall, but when to go to the hospital and what to watch out. Like I have a list on the wall for my epilepsy, so they know when to go to the hospital, when not to go, and what to do and stuff like that when it happens.
That's awesome.
Yeah.
I am a big advocate for safety plans, regardless of whether that be neuromuscular, whether that be any physiological plan or mental health plan too. So I have a lot of clients now with suicide plans, right? When they're feeling suicidal, this is their plan. This is who to contact. This is what to remember. So these are all things that can be beneficial to kind of skating back through wellness, right? On the way to wellness. So one more thing to go through here is schizophrenia. Oh, apologies, guys. Sorry. Schizophrenia. So positive. And by positive, just to let you guys know, positive means additional experiences. So there's positive and negative symptoms of schizophrenia. And it doesn't mean that positive is a good and bad kind of symptom. Positive means an additional experience. So they're having an additional experience like a delusion or a hallucination. So they may act in accordance with false beliefs, which is a delusion, and be responding to stimuli that aren't there. And that's a hallucination, right? Whereas negative symptoms is the lack of things that are normally present in the individual's life. So whether that be abolition, so lack of motivation, anhedonia, inability to feel pleasure, asociality, lack of interest in social interactions, blunted affect, which is diminished expression, or what am I forgetting? Alcoholia. which is the reduction in speech. So those are all negative symptoms that can be presented with schizophrenia. So my favorite part about the presentation is treatment options or support services. What are some treatment options or support services offered today as coping mechanisms, techniques, and interventions to individuals experiencing mental health issues or mental illness? Can you guys think of any on the top of your head?
Walking a dog.
Walking a dog?
Walking a
Counseling,
dog.
Linda, is that what you said?
Yeah.
Yeah. Anyone else? Tony?
Medications, and I agree with Manly, walking. I get out 3 or 4 times with my little schnauzer, so it's
Awesome.
great. It's great therapy.
Kelly?
And you talk to people on the way. A lot of dog walkers. I mean, this morning it was a 15-minute walk, but it took us an hour because we're talking to so many people.
Yeah, socializing is another one, right?
Yeah,
Kelly, what were you
exactly.
going to say?
My daughter just went through mental health issues and spent 3 weeks at our mental health unit at our hospital.
Okay.
But there was a 4-week, 28-day program where she learned how to deal with things, like whether it was just to make a meal or to get up in the morning and to get her hair done and to put her makeup on and to get dressed to go to a class. And she also learned that she needs to take time for herself. And she painted for the first time that she was there and found things that were enjoyable. So she likes to walk at the beach because I live in Prince Edward Island. So she goes to the beach quite often, at least once a week, to pick sea glass. She's started to knit again and has found things in her life that are enjoyable and that keeps her mind and gives her enjoyment instead of being in that dark spot all the time.
Yeah, and I think it's important to note that it's individualized, right? Coping mechanisms are very individualized.
That's right.
Going along with what you said, though, in those programs, I think they crave structure and routine because we are such routinistic mammals. Humans in general, if you strip us of all routine, we will falter in some way, whether that be in physical or mental health, we will falter. So developing some sort of routine, and it doesn't have to be the same routine every day, but developing some sort of stability in life is very important on getting a grasp on mental health. So I do like how you mentioned that program probably involved cognitive behavioral therapy. So learning how our behaviors and thoughts and emotions all intertwine together. So whether you seek out support from clinicians or counselors or therapists or doctors or from each other, I think it is important to note that we are connected beings and we do crave connection. So it's important to kind of lean on each other. It does take a village to get through this life, and it's much healthier and happier when you have support people, right? And this goes in line with what everyone said: medication, counseling, therapy, family peer support, early intervention, academic and holistic. But lifestyle, I wanted to touch on to this because an adequate amount of sleep, going again, I am a little bit of a nerd. I did my thesis in sleep deprivation. It is so important. It increases our amyloid plaques in our brains, which leads to further brain disease if we don't get an adequate amount of sleep. So sleep is very, very important. Healthy eating, how our gut microbiome connects to our brain is very, very important too. Exercising when we can, hobbies and interests, and it gives us all of these things, give us a sense of purpose, right? So have any of you does anything touch with you guys that you've done in your daily practice, in your daily life? Tina, sorry, go ahead.
Actually, since you talk about sleep, I just had a question because I saw my doctor today and I haven't been sleeping in over 4 or 5 months. I wake up twice a night, 1 o'clock and 4 o'clock, almost on the dot.
Okay.
I've been able to fall back asleep after the 1 o'clock, but I can't after the 4 o'clock. I keep saying I have 2 or 3 more hours. So my question is, like, I went to the doctor today and they just want to put me on more medication. And I'm already taking something for anxiety, and it's supposed to be a sedative as well. But what I've researched so much natural things that you can take, that everything is contraindicated with this one medication, which is Remeron. I might as well just say it. So what else? What are my options? Like, just take this other medication they give and hope for the best, or yeah, just if you can talk about more about sleep, because
Yeah,
I'm
so
sure it affects all of us.
so I can talk a little bit more. I'm not going to give you any recommendations. I think I would encourage you to talk with your doctor about all of these suggestions, but I will say that there are some routines just behaviorally that we can take away that do uptake our melatonin. And melatonin is a natural neurotransmitter in our brains already. I'm not talking about the supplement, I'm just talking about natural. So oftentimes people have a lot of screen usage before bedtime. Oftentimes a lot of people do that screen usage in their bedroom. So if you're having trouble sleeping, one of the first things to do is make sure that you are not doing your everyday tasks in the bedroom or in your bed, because your bed is supposed to be associated with sleep. So if you're having trouble sleeping, make sure that your daily activities is happening outside the bedroom. I would encourage any type of reading before bed, if it could be paperback. I know we live in a society of modern technology now, but if it could be paper, that would be something that I would recommend before bedtime. Nothing overstimulating. So we live in the age of Netflix and TV and everything at our fingertips. But if you could prevent yourself from doing that a half hour before you want to get to bed, that would be beneficial. So those are all things that I can suggest. If you're having ongoing issues, I would definitely give the doctor's recommendations some listening to. But I think that, has anybody ever tried progressive muscle relaxation? It sounds like a really fancy word, but have any of you heard of this?
Yeah, I've tried it. It doesn't, all it does is set me up for more muscle spasms.
Okay, yeah.
And one thing about MG is many people have sleep problems related to their myasthenia. And if everybody hasn't had a sleep study, that's the first thing to do. Because I was having a sleep study, they found out I was gasping for air in the night because my oxygen was dropping. And that's why I wasn't sleeping from 4 o'clock on. So everybody needs to look at the one step past just the talking to the doctor if they have myasthenia gravis.
So that's so funny, yep. Kathy. I was just going to mention, I recently, not recently, sorry, years and years ago, I spoke with a respiratory therapist because I had a sleep study done and I was also gasping for air, and I had to have this huge surgery, and because I wasn't breathing at night. So that could also attribute to your lack of sleep, right? So it is important to kind of grasp all of our options here. But yeah, and your doctors should be recommending that course of treatment too, if they've really extensively gone through the list of what to look for. So that's something to be talking about too.
Can I add to Tina? I was just going to suggest perhaps doing breath work or meditation. There's a free app called Insight Timer that I find since my diagnosis, I am meditating first thing in the morning, and I'm meditating before I go to sleep. And I, like you, Tina, I wake up not twice, but I guarantee, like clockwork, 3 o'clock in the morning. And I'm like kind of that borderline. I've got 3 more hours of sleep. And sometimes I have a hard time. I just put on a sleep app and it just brings me right back. Whether it's like just music or a simple 5-10 minute meditation, just cued, I find it's really helpful. So maybe worth trying, and it's free. So,
yeah, that's great. There's another app
Yeah.
called Breathe that's the same
Yeah.
thing, Tanya.
Yeah, I've heard of that too. So I find because we're all struggling because we all have MG, and whether it's a medication that's keeping you awake or your bladder or what, there's so many things that can contribute to why we don't sleep, you know? So I'm like trying everything except melatonin, but I'm just trying to find all the natural ways too. So since you mentioned natural, I'm like breath work.
Yeah, I would err on the side of natural first and then pharmaceutical. And that's just me in my practice. That is not kind of oversharing with you guys, but grounding techniques also, it's also called earthing. It's a therapeutic technique that's involving activities that ground or electrically reconnect you to the earth, so that whether that be immersing yourself in water, whether that be laying physically all on the ground, whether that be taking your shoes off and touching the ground with those breathing techniques, as Tanya mentioned, those are all great things to try in the interim before the pharmaceutical realm. And you know what, pharmaceutical realms paired with behavior is with behavior counseling and therapy are awesome in conjunction, but I don't think that they necessarily go one or the other. I think they should be used in conjunction. Sorry, Tony, you were going to share.
Yeah, I was going to say I wear a smartwatch to bed, and it tracks all my every time I get up, and it says I'm sleeping 6 to 7, maybe 8 hours a night, and it gives a score, but I still feel tired at the end of the day.
Yeah, so I think that is kind of cool because you can bring that to your respiratory therapist if you ever
Right.
got to see one, and they can see where they can compare, because not always does a sleep study capture or encapsulate to what you're going through every single night. So sometimes you do have to do more than one if they don't capture anything. It's just the luck of the draw. Sometimes, you know, you're saying to a doctor that this is happening, and then you go and see them and that thing is not happening until
Yeah,
right as soon as you walk out the office, right? Go ahead, Linda.
Okay, with me, I did the sleep study and found out that I have to use a ventilator
Okay.
at night.
Like CPAP?
No, it's an actual ventilator.
Okay.
I failed the CPAP and the BiPAP. But one thing I find really helpful is pet therapy, just spending some one-on-one time with my dogs, and they can sense when I'm not doing really well or that. And they're my nurses. They're right beside me and making sure everything is okay.
That's great.
When I first went on prednisone 3 years ago, I didn't sleep at all. And I'd be lucky to get 3 or 4 hours a night. I tried the melatonin, that didn't work. Then I was diagnosed with thyroid cancer, had a lot of issues of trying to get to sleep. And my neurologist was okay with me taking a CBD gummy at night. And it was wonders. Then I was getting some sleep. I don't take any of them anymore because now I sleep lovely, because I have my other prior health issues have gotten better, so they're not a big worry on my mind. And I off my iPad about a half hour before I go to bed, and then I read once I get into bed for a half hour to an hour with large print paperback. And now I sleep a lot better than I did last year, 2 years ago, or 3 years ago. And I found that just that little bit of CBD gave me enough to let me sleep properly and get a half decent night's good rest.
Yeah, and I think that it's important to note that like we're all going to experience things differently and find things that work for us differently, and to make sure that we share this with our doctor before we kind of
and
get
my
going.
neurologist, he was like, if that's what helps you, because I tried the melatonin, like taking, and I was like, okay, I'm not doing any different.
Yeah.
So 2 to 3 hours, tops 4 hours, I was like, I was wiped out. So I asked him and he said, if that's what works for you, Kelly, then yes, because you need your rest instead of taking another prescription.
Yeah. Yeah, and I'm so glad that you found something that works for you and that kind of works in line with your treatment towards your doctor too.
Yeah.
That wraps up my presentation though, guys. It was lovely to meet all of you.
Thank you.
Thank
And
you.
Thank you so much.
Thank
It
you.
was, I enjoyed that presentation. Thank you. I learned a lot.
awesome to hear. I would love to do it again anytime.